who is a neurology clinical specialist at Believers Church Medical College Hospital, Kerala. I feel really grateful to introduce our speaker to you people. He is a very honored one with an emerging voice in clinical pharmacy and research. Dr. Atul H, a dedicated Doctor of Pharmacy graduate from Nazareth College of Pharmacy affiliated with the Kerala University of Health Sciences, did his PharmD course from 2018 to 2024. Currently serving as a neurology clinical specialist at BCMCH, Dr. Atul is also an ambassador of RX Doctors and an active member of the British Society of Antimicrobial Chemotherapy. His clinical practice is focused on enhanced patient care, medical safety, and interdisciplinary collaborations. Dr. Adul has been instrumental in providing patient centered medication counseling and resolving drug related problems, participating in multidisciplinary team meetings to optimize therapeutic plans, advising patients on drug side effects, contraindications, and proper usage, assisting in pharmacovigilance through adverse drug reaction reporting and literature based query resolutions, contributing to clinical research with hands-on experience in data processing, review, and regulatory compliance under ICH, GCP, and SOP frameworks. With a deep interest in translation research, he has authored and co-authored numerous publications, case reports, and review articles spanning drug repurposing, AI in dermatology, and the role of telemedicine in patient care. With clinical precision, research rigor, and a patient first approach, Dr. Atul Head stands as a passionate young leader in the pharmacy profession. And today, he'll be speaking us about the topic of neurocare, that is, clinical pharmacist role in neurological disorder. As an intern, I've been hearing about the importance of the pharmacy graduates in the sectors of oncology, pediatrics, and stuff. But having a role in neurological condition is really peculiar and has to be heard out so much. So let us extend a warm welcome to Dr. Atul as he shares his insight and experience with us today. Welcome, sir.
Good evening, all. Am I audible?
Yes, sir.
So, is my screen visible?
Yes, sir, it is.
Good evening, all. And thank you for that bright welcome wishes. And thank you, Bharat, and all the SYCCON members for giving me an opportunity. So, today I'll be discussing how a clinical pharmacist improve patient care, safety, and outcomes within a neurology department. So, neurology is a complex specialty requiring patient-centered care and is often delivered by a multidisciplinary team, including the physician, the pharmacist, the nursing team, and all other supporting members. The clinical pharmacists are medication experts. We work directly with the patients and healthcare teams to optimize the drug therapy and improve outcomes, especially these are important in a complex population like the neurology patients. Can someone please tell me some of the neurological disorders that you have seen or you know about? Hello? Yeah. The neurological disorders include Parkinsonism, strokes, myasthenia, dementia, epilepsy, stroke, etc. So the patient often require multiple medication, sometimes with significant interactions. Making safe and effective pharmacotherapy is crucial. The clinical pharmacist roles include medication management and optimization, medication reconciliation and review, drug interaction monitoring, patient and staff education, multidisciplinary team collaboration. We can ensure medication management and optimization through guiding therapeutic decisions, ensuring safe transitions, adverse effect, and drug interaction monitoring. The patients are at high risk for medication errors and ADRs. We clinical pharmacists vigilantly reduces the medication-related harms by proactively identifying the interactions and adverse effects. We also play a key role in creating the standardized treatment and monitoring protocols for high-risk neurology medications. ensuring that the safe use of medications throughout the department. We are also involved in direct patient care, counseling the medication regimens, especially for the new therapies, counseling the patients regarding the medication device use or the self-administration techniques. While getting the discharge, the clinical pharmacist can guide or counsel the patient and the caregivers about the drug indications, what all to be monitored, and the need for medication adherence. Multiple studies have proven that adding clinical pharmacists to the neurology team increases the treatment efficacy, improves medication safety, and adherence. We are also involved in the staff training and patient training sessions, also supporting the research and quality improvement projects, and also involved in the student teaching of the medical students, pharmacy students, and nursing students. Also, the clinical pharmacists are involved in managing the complex neurological disorders by providing specialized support, providing sensitive period, providing proactive medication management during pregnancy and the sensitive period, conducting telehealth visits, improving access for the limited patients, monitor surveillance, tests, and side effects of the complex infusion treatments. Other roles include monitoring, conducting the specialty clinics, including the multiple sclerosis, stroke clinic, movement disorder clinic, epilepsy clinic, headache clinic. In epilepsy, there is increased chance of having due to the polypharmacy, there is increased chance of providing more ADRs. The clinical pharmacist monitors serum concentration of the anti-epileptics, so to ensure that the levels are within the therapeutic range. This will help in minimizing the toxicity while maximizing the seizure control. Dosage adjustment are often necessary due to the adverse effects, like when we are giving valproate to a patient. What is our adverse effect? There high risk of hepatotoxicity, or while giving levetiracetam, there is high risk for behavioral issues. We also educate the patients and caregivers about the need for adherence and the possible side effects that can occur and what all to be monitored. We're also involved in the movement disorder clinic and Parkinson's clinic, in the headache and migraine clinic, guiding the patient so that it so that they're so that they can be more adherent to the therapy. Also in immunological disorders, where if a patient is selected as a candidate for rituximab, for example, the rituximab works by depleting the CD20 monoclonal antibody that makes the patient under high risk for infection. So checking for infection in these patients prior to the infusion will help in reducing the present progression of new infections and also reactivating the latent infections. So we usually check the counts, the infective parameters, check for hepatitis and stuff while before giving the rituximab. So let's go forward with the case discussion. Here I have chosen a stroke case. Can someone say what is stroke and what are the types of strokes? So stroke is a medical emergency caused by the interruption of the blood flow to the parts of the brain, leading to cell death. And it is considered as one of the major causes of mortality and morbidity worldwide. Mainly, strokes are classified into three: that's acute ischemic strokes, hemorrhagic strokes, and transient ischemic attacks. So the acute ischemic stroke or the ischemic stroke account for the approximately majority of the stroke. It occurs when a blood clot blocks the blood vessels from supplying the brain, often due to atherosclerosis. The ischemic stroke may be due to can be classified into thrombotic stroke, embolic stroke, lacuna stroke, and caused by large vessel occlusion. Management mainly focus on the rapid restoration of blood flow and the intravenous therapy or the endovascular thrombectomy if the patient is presented within the window period, and secondary stroke prevention. In hemorrhagic stroke, it comprises of a lesser amount compared to the ischemic stroke. This occurs when a weakened blood vessel ruptures, causing bleeding in or around the brain area. And it is comparatively more lethal compared to the ischemic strokes. Common causes include uncontrolled blood pressure, aneurysm, or arteriovenous malformations. Management strategies include stabilization and supportive care, including BP control, discontinuation of any anticoagulations, possible neurosurgical interventions, including the decompressive craniotomy, aneurysm clipping, coiling. And the last one is transient ischemic attack. It is caused by temporary blockage, causing stroke-like symptoms, and is resolves less than 24 hours without permanent damage. But it also serves as a warning for potential stroke. So patients should be counseled regarding the lifestyle modification, put on secondary stroke prevention medications like antiplatelets. So this is a 50-year-old male weighing around 56 kilogram, presented to our department with complaints of acute onset right upper limb and lower limb weakness with speech. He had known history of hypertension, on metformin and telmisartan. So patient's symptoms started at 6:30 a.m. and presented to the emergency department at 8:30 a.m. on the same day. So what is the window period for IV thrombolysis? Yes, 4.5 hours. So on examination, patient had GCS E4, V5, M6, that is full GCS, and he was vitally stable, and he has difficulty in speaking, and the power of the right side was a little low compared to the left side. And there was right upper and lower limb drift that is caused by the weakness, and there's upper limb ataxia. So he had an NIHS 4. We did an imaging as fast as it possible, and the MRI showed an acute infarct in the left middle cerebral artery, in the left parieto-temporal and left insula, and there was no associated flare change. So in MRI, there are many sequences. The flare sequence is used to check whether the patient is within the window or out of the window. If the patient is out of the window, there will be early radiographic changes in the flare window. So as you can see, there is an acute infarct in the middle cerebral artery area. So the patient presented within the window. So we gave them the option for IV thrombolysis, and the relatives were also consented for the same. So IV thrombolysis is frontline emergency for the treatment of acute ischemic stroke and uses the tissue plasminogen activator, which works by activating plasminogen and converting it to plasmin and breaks down fibrin strand in the blood cords. The time is brain is an important thing we need to remember while doing this in the acute cases, as each second is valuable because destruction of neurons takes place. And the most commonly used drug is alteplase. Newer agents like tenecteplase are also being used in some settings. So we cannot blindly give thrombolysis to a patient. There are some contraindications and there are some criteria which the patient has to. The absolute contraindications include a recent acute intracranial hemorrhage or a history of intracranial hemorrhage, severe uncontrolled hypertension, serious head trauma or stroke in previous 3 months, thrombocytopenia or hypercoagulopathy, severe hypoglycemia, hyperglycemia, and early radiographic ischemic changes. So in these cases, there are increased risk for bleeding. And if you can see, I have mentioned severe hypoglycemia or hyperglycemia. These can present as a stroke mimic. Stroke mimic are conditions that are actually not stroke, but present as stroke symptoms. The relative contraindications include advanced age, mild or improving stroke symptoms, severe stroke and coma, recent major surgery, recent gastrointestinal origin hemorrhage, seizure at onset. Seizure can also present as stroke mimic and any CNS lesions, recent myocardial infarction. So the majorly used IV thrombolysis are the tenecteplase, which is given as a single IV bolus over 5 seconds. The dosing is like if the patient is weighing less than 60 kilograms, the 50 mg is used, 60 to 70, 17.5 mg, and 70 to 80, we are giving 20 milligram, and 80 to 90, 22.5. And if the patient weighs over 90 a 25 milligram is given. The next is alteplase, which is given as calculating dose of 0.9 mg per kg per hour. It was given as first as a bolus dose as 10% of the total dose, and next remaining is given as an infusion over 60 minutes. We usually use alteplase as studies have proven that alteplase has less chance of post-thrombolysis bleed. So here I'll explain how the alteplase is given. I have taken these pics from the Activate site. First, we need to remove the protective caps and clean the area. And it includes a Activist is available in lyophilized powder, and also there is sterile for water for injection, and there is a spiking vessel. We use the injector to pick the sterile water for injection. Then the alteplase is at the right the other end. Next, the alteplase is pushed down, and we invert the vials so that the water comes slowly. We cannot rapidly mix the alteplase as it is cause degradation and bubbling. Once it's fully transferred, the sterile water formation vial is discontinued. We need to check for whether there is any remaining that needs to be diluted or not. And while giving the alteplase, it should be noted that the patient is having low BP is under control, or the patient is not having any another symptoms like vomiting, headache. If patient is experiencing any type of these symptoms, we need to suddenly stop the infusion, or also we need to check for any anaphylactic reactions while giving this. So the patient was given 50 milligram of alteplase with strict monitoring of the blood pressure. He was admitted in the ICU and was started on statins and other supportive measures. His follow-up brain and after the 24 hours of IV thrombolysis showed no hemorrhagic transformation. He was initiated on antiplatelets and was started on physiotherapy, speech therapy. His symptoms improved and he was discharged in a stable manner. So if we are giving alteplase, why can we give? Why can we? Why do we need to do a follow-up imaging after giving any thrombolysis therapy? Like what we look for after a post-thrombolysis therapy? What are we looking in next imaging? So we need to check for post-thrombolysis bleed as giving alteplase can increase risk for bleeding. So a repeat imaging is taken after 24 hours of the thrombolysis if the patient is stable, or in between if patient is experiencing any symptoms, we need to take an imaging as fast as possible. If there is increased bleeding and there is midline shift of mass, neurological interventions might be. Suppose the same patient presented after 2 years with another stroke. What might be the reason for this stroke? Can anyone say? He was injected on antiplatelets and he was counseled regarding the medication adherence, and but 2 years he came with another stroke. What might be the reason for that stroke? It can be either due to any underlying cardiological factors or non-adherence to the medication. Yes. Also, some patients might be show resistance to these antiplatelets. So we need to do a clopidogrel resistance test or the platelet aggregometry test to check whether the patient is having any resistance to these. So let's wind up our session. So the key take home messages include that the clinical pharmacists play a vital role in neurology department as an essential members of the healthcare team, ensuring safe and effective care of medication with patients with neurological disorders. So thank you all. And it was a little fast. Is there any questions you might want to ask?
If you have any questions regarding this topic, then feel free to share it in the comment section. So we can wait for a minute, and if there is no anything, we can wind the sessions. So we do have a question from Shiba. In case of recent surgery, altiplate shouldn't be administered, sir.
Yes, we cannot give alteplase in case of a recent surgery because it increases the risk for bleeding.
And another question. So recently, stroke cases are increasing, although patients have no past history of hypertension and DM. What might be
Yeah,
the cause?
we are also seeing patients with who have no comorbidities presenting at our center with strokes. Some might be attributed to the genetic causes, but the exact etiology is under evaluation.
And with that being said, I think that's all the questions from our audience. Thank you so much, sir. Thank you so much for giving a valuable insight on the neurology department where the clinical pharmacists need us. Thank you so much, sir. Thank you so much for having us today.
Thank you.
And thank you so much, everybody, for sticking us with us till this end on this day 4. And your feedback forms are shared in the comment section. Please feel free to give us your valuable feedback. It's truly appreciated and will help us to improve and understand your requirements and your demands too. So, with that, we are going to wind up the fourth day of the SYCCON Series 6. And tomorrow, there is a very good package for you with same 3 speakers are going to have us to tomorrow. The speakers are going to be Dr. Risha Goya from CEO and co-founder Dual Spear Consulting, and she'll be speaking on the future of HEOR, skill scope, and global opportunities. And Dr. Sai Priya, PharmD residency program in CP nephrology, JSS Chief CP Aishwarya Hospitals, Chennai. And she'll be speaking about renal pharmacy residency, the reality check. And our last speaker, Mr. Balamurugan, is medical documentation specialist at OG Healthcare Private Bangalore, Karnataka, on the topic of kickstart your career as a medical scribe. So tomorrow is going to be super exciting session for you and a very valuable insight too. With that being said, once again, please do give your feedback in the comment section where the links have been shared. And Thank you so much, everybody. Let's wind the session. It is sixth international conference of RX Doctors SYCCON. Yes, sixth Stereo Career Conference Series, sixth ultimate career destination for pharmacy aspirants, organized by RX Doctors, organizing partner STA Premier Clinical Research Institute, and I am Jennifer, and the entire team of RX Doctors signing off. Good night, everybody.